doctors gathered here. At the outset, I'd like to thank Professor Dr. Vitull Gupta for giving me this chance to interact with all of you on the topic of patient blood management. So, patient's blood management actually is a multimodal approach which starts right from the moment a patient walks into the OPD. All this is all centered towards a better patient outcome by managing a patient's anemia, then employing patient-centered decision-making, then coming to the aspects of coagulation by optimizing the coagulation therapies and interdisciplinary blood conservation modalities. They all get together and result in a better patient outcome. So first of all, managing a patient's anemia. We all should be focusing the treatment to create methods for early detection of anemia, increasing the physiological tolerance of anemia by minimizing the oxygen consumption, employ timely evidence-based pharmaceutical and nutritional intervention to support erythropoiesis, determine the causes and contributing factors of the anemia, and apply evidence-based rationale for the use of red cells. Coming to patient-centered decision-making. Every patient who visits the OPD should be listened to carefully, his desires, his concerns, and the treatment possibilities should all be patient-centric. Patient should be provided with all the current information that is there about patient's blood management interventions. Inform the patient about the risks, benefits, and alternates of all the treatment choices available. He should be given all the options other than receiving a blood transfusion during all elective surgeries. He should be taught about autologous blood options and erythropoietic stimulating agents. All this should be done prior to all elective surgeries. Integrate patient values and autonomy in decision making. Coming to optimization of coagulation, in this we need to evaluate both the quantitative measures to assess true coagulation status. Here I'd like to mention that prothrombin time and APTT tests like these that we are using for assessing the coagulation status of the patient may actually not reveal the true status in many cases, like as in liver patients. Actually, we should truly assess the real cause of the bleeding dysfunction, employ goal-directed therapy to correct any coagulation abnormalities, and again apply evidence-based rationale for the use of plasma. Coming to interdisciplinary approach for blood conservation modalities, adoption of precise surgical techniques using all available methods of hemostasis, rapid diagnosis and prompt arrest of blood loss in all situations, employment of intraoperative blood conservation modalities, using of intra and post-operative autologous blood conservation modalities, and controlled diagnostic blood loss. Here I'd like to give a special mention to autologous blood use, which should be explained, and the option should be given to all patients coming to us for elective surgeries. The three pillars of patient blood management. The first one is the optimization of a patient's own red cell mass, proper diagnosis and treatment of iron deficiency anemia, cessation of medications, choosing a proper time for surgery so that the patient can optimize his own red cell mass till the time he is posted for surgery, management of post-op anemia and iron deficiency, and managing the patient's post-op medications and potential interactions. Coming to the second pillar, which involves the surgical blood loss, that would be minimizing the surgical blood loss by anticipating the bleeds, the risk of bleeding, minimizing phlebotomies in the wards, and timing of the procedure should be correctly decided. Achieving a meticulous surgical hemostasis during and in the post-op period. Cell salvage can be done in many surgeries, cannot be done in many surgeries. That has to be decided along with the surgeon and the transfusion medicine consultant. Patient positioning during surgery and additional care to the patient, like keeping the patient warm and using proper pharmacological agents like tranexamic acid these days and erythropoietic stimulating agents. Post-op monitoring, that should be very meticulous. Again, post-op management, keeping the patient warm, minimizing phlebotomies in the wards and treating any concomitant infections. Coming to the third pillar, that is management of the patient's anemia with any bleeding histories if the patient has, estimate the anemia tolerance, optimize the cardiopulmonary dysfunction so that the patient, even if is left slightly anemic, can tolerate the anemia better. Optimize the oxygenation and restrictive transfusion strategies if we are following. In case the cardiopulmonary dysfunction is corrected, the patient always tolerates the anemia better. Now coming to the components of blood and proper use. The potential of human blood is actually still unexplored. But now in the era of component therapy, we advise the use of components. Here we should actually know the real use of each and every component. So human blood is composed of, whenever we take a unit of whole blood donation, we segregate it into various components. Coming to red blood cells, they increase the amount of red blood cells after trauma or surgery to treat severe anemia. This is a packed form of red blood cells which gives us a better increment in the hematocrit of the patient. 1 unit of packed red blood cell increases the hemoglobin by 1 gram or hematocrit or the packed cell volume by roughly 3%. Fresh frozen plasma to correct the deficiency of coagulation factors or to treat shock due to loss of plasma, as in case of burns or massive hemorrhage or bleeding, which is actually rich in factor 5, 8, 9, 10, 11, 12, 13, von Willebrand factor, fibrinogen, fibronectin and thrombin. Coming to concentrate of platelets, which you normally call a platelet concentrate or random donor platelets, which increases the platelet count by 5,000 to 10,000 per microliter, and 1 unit a larger single donor apheresis platelets or SDP or STAP increases the unit platelet increment by 40 to 60,000 per microliter. To control bleeding due to platelet loss, like as in dengue or dengue shock syndrome, or due to platelet coagulation problems. Cryoprecipitate to treat fibrinogen deficiencies rich in factor 8, 13, von Willebrand factor, fibrinogen, fibronectin. The preferred modality of treatment in hemophilia and various factor deficiencies. Coming to packed red blood cells. Now coming to the American Association of Blood Bank clinical practice thresholds that are given, the first recommendation is actually a restrictive transfusion threshold of 7 grams per deciliter in hospitalized adult patients who are hemodynamically stable, including critically ill patients. A threshold of 8 grams per deciliter can be kept for patients undergoing orthopedic surgery, cardiac surgery, and those with pre-existing cardiovascular disease. However, this is not applicable to patients with underlying heart disease, acute coronary syndrome, severe thrombocytopenia, and chronic transfusion-dependent anemia. The second recommendations would be patients, including neonates, should receive red blood cell units selected at any point within their licensed dating period. That is a standard issue rather than asking for fresh blood. Because actually the storage length, if in case you say that fresh is anything less than 10, actually now the fresh guidelines advise us that fresh is anything up to even 28. Since now we have additional storage techniques like advanced plasticizers, phthalates, then advanced storage solutions, they all have taken the storage life up to 42 days. So coming to transfusion support in critically ill patients. Here, according to the British Society of Hematology, first assessment lies there with the clinician, that is the patient anemic and hemodynamically stable? Yes. And if the HB is more than 9 grams per deciliter, we do not need to go ahead with the blood transfusion. However, if the patient has an underlying heart disease, an acute coronary event, a severe sepsis or a neurological injury, we can use a critical trigger of 7 and maintain a HB of 7 to 9 grams per deciliter. In case of severe sepsis, if it is early onset, less than 6 hours from onset and evidence of tissue hypoxia is there, we can go in for a target HB of 9 to 10 grams, and late onset sepsis, again we can follow an HB of more than 7. In case of neurological patients, critical care, neurocritical care, there is evidence of head injury, traumatic brain injury or subarachnoid hemorrhage, the HB preferred is always more than 8. In case of ischemic heart disease, acute coronary syndrome, a target HB of more than 8, and patients with stable angina, again we can keep a HB of 7 to 8. So these are all clinical decisions actually, and depending upon the condition of the patient, the clinician is the best. Transfusion threshold of 70 grams per liter or below with a target HB range of 7 to 9 should be the default for all critically ill patients unless specific comorbidities or acute illness related factors modify the clinical decision making, and transfusion triggers should never exceed 9 grams per deciliter in most critically ill patients. So this is again a tabulated form for severe sepsis and inadequate tissue oxygen delivery, or depending upon the stage of sepsis. In traumatic brain injury, like I earlier said, it should be kept from 7 to 9. Again, in neurological traumatic brain injury, cerebral ischemia, subarachnoid hemorrhage, the threshold can be taken up to 9. Pre-transfusion clinical assessment is to be done. Concomitant medical conditions that predispose the patient to any transfusion-associated circulatory overload, like as in cardiac failure, renal impairment, hypoalbuminemia or fluid overload should be ruled out. Rate of transfusion together with careful fluid balance and appropriate use of diuretic cover, that is Lasix or furosemide, can reduce the risk of any transfusion-associated circulatory overload. Patients who develop acute dyspnea with hypoxia and bilaterally pulmonary infiltrates during or within 6 hours of transfusion should be carefully assessed for any evidence of transfusion-associated lung injury, and supportive treatment and monitoring of the patient should be more strict in such cases. Hospitals should have a strategy to ensure that red blood cells are readily available for life-threatening bleeds. However, in case of emergency, group O red cells can be transfused. However, in this case, the patient must have correctly labeled samples taken prior to the administration of any group O red cells. Like as I earlier said, there is no indication of fresh stored red cells, that is under 7 or 10 days in case of hemorrhage. However, in case of gastrointestinal non-massive hemorrhage, a restrictive strategy of red cell transfusion is recommended for many patients. Coming to the Australian guidelines for critically bleeding patients, a critical bleed is a major hemorrhage that is life-threatening and likely to result in the need for a massive transfusion. Here also they say that permissive hypotension and minimal volume resuscitation is preferred over aggressive volume resuscitation while active bleeding is being controlled. However, this is contraindicated in patients with possible traumatic brain injury, and in critical bleeding patients, hemoglobin should be interpreted in the context of hemodynamic status, organ perfusion and tissue oxygenation. Now coming to red blood cell transfusions in chronic kidney disease patients, here we have to assess. There are special conditions where chronic kidney disease patients are present, that chronic severe symptomatic anemia relatively contraindicated to an erythropoietic stimulating agent. For example, a current or previous malignancy or a previous stroke, and is the patient a potential transplant recipient. However, in this case, it is better not to transfuse because you are sensitizing the patient, alloimmunizing the patient prior to a transplant. In case he is a prospective transplant candidate, there the risk of transfusion far outweighs the benefits. Coming to nephrology guidelines, in international guidelines in renal patients, while managing chronic anemia, avoid red cell transfusions to minimize the journal risk related to their use. In patients eligible for organ transplantation, avoid when possible red cell transfusions to minimize the risk of alloimmunization or allosensitization. When managing chronic anemia, it is suggested that the benefits of red cell transfusions may outweigh the risks in patients in whom erythropoietic stimulating agent therapy is ineffective, for example hemoglobinopathies, bone marrow failure or ESA resistance. The risk of ESA therapy may outweigh its benefits, like as in previous or current malignancy or a previous stroke. Coming to UK Renal Association transfusion guidelines, In patients with anemia of chronic kidney disease, especially those in whom renal transplantation is an option, red blood cell transfusion should be avoided where possible to minimize the risk of allosensitization. Those on transplant waiting lists or patients on immunosuppressive therapy should receive only hepatitis E negative blood components. Hepatitis E negative screening has still not been mandatory by Government of India. Coming to transfusion strategies in myocardial infarction, the results of a trial indicate that a restrictive PRBC transfusion strategy, HB less than 8, is non-inferior to a more liberal strategy. At 30 days, infections and acute lung injury were always higher with the more liberal strategy. Now again coming to RBC transfusion in cardiac disease, that here if we take the threshold as 10 grams per deciliter, we have to see whether the patient is symptomatic or asymptomatic. Any symptomatic cardiac disease, we have to keep the HB up to from 9 to 10. And when the decision comes to no coronary artery disease, the trigger can be kept as low as 7. Now coming to a restrictive versus liberal transfusion, various trials have been conducted in history to decide whether a restrictive threshold is better or a liberal transfusion threshold is better. However, the results were comparative. For upper GI bleed, survival at 6 weeks was higher in the restricted group. For septic shock, comparable results. Acute coronary syndrome, variable results. Cardiac surgery at 8 and 10, comparable in both the groups. However, for oncology patients, liberal group had superior results. And again for neonates and children, comparable outcomes in both the groups. The various trials that have occurred are the TRIC was one of the most famous trials in history, FOCUS, then TIATR 2. Now, TRIC trial has showed that the number of units transfused, mortality was lower in the restricted group. According to FOCUS, for surgical hip and fracture repair, mortality comparable in both the groups. However, for cardiac surgery patients, 30 days mortality was comparable, no difference in infectious events, sepsis or wound infections. Coming to platelets, for therapeutic platelet transfusions, for major bleeds, the platelet count has to be kept more than 50,000. Consider the empirical use for initial management of major hemorrhage. In case of patients with multiple trauma, traumatic brain injury or spontaneous intracerebral hemorrhage, the count has to be kept more than 1 lakh. In patients with bleeding that is not considered severe or life-threatening, the count can be tolerated up to even low as 30,000. For platelet functional disorders, congenital like as in factor deficiencies or Glanzmann thrombasthenia, we can consider recombinant factor 7A and tranexamic acid plus desmopressin in congenital platelet function disorders. Further, HLA matching has now been started for platelets, not in our centers but advanced centers now, and soon we will be also getting HLA matched platelets. Glanzmann thrombasthenia, where we have actually a form of thrombasthenia, HLA matched platelets are the treatment of choice. For acquired functional platelet disorders, do not use platelet transfusion pre-procedure when antiplatelet agents have not been discontinued. You should consider drug cessation and reversal of the co-prescribed anticoagulants. Tranexamic acid can be used to counteract the effects of antiplatelet agents when a risk-benefit assessment would be better supporting the use. Consider the use of platelet transfusion as an additional measure to those suggested above for critical bleeding. These are the thresholds for most invasive surgeries, including a bypass, minimum of 50,000. For neurosurgery or eye ocular surgeries, the count has to be kept to 1 lakh. Prevention of bleeding associated with invasive procedures, for a lumbar puncture, it has to be 50,000. Central line insertions, 50,000. Liver, renal or transbronchial biopsies, 50,000. A GI endoscopy with a biopsy, 50,000. For spinal and epidural, for spinal it is 50 and for epidural it is 80. Now coming to the thresholds by the British Society of Hematology. Prophylactic use with no bleeding or WHO grade 1 adult dose Reversible bone marrow failure including allogenic stem cell transplant, you can keep it up to 10,000. Reversible bone marrow failure with autologous stem cell transplant patients can be 10,000. Critical illness, again it can be 10. Chronic bone marrow failure receiving intensive therapy, 10. Chronic bone marrow failure to prevent persistent bleeding more than grade 2 or variable count. Now, prophylactic use in the presence of bleeding, that is sepsis, antibiotic treatment or abnormalities of hemostasis, it can be taken up to 20,000. Now, these are the British guidelines. Coming to the use of fresh frozen plasma. There is no evidence to support the prophylactic use of fresh frozen plasma in non-bleeding patients with abnormal standard coagulation tests, even pre-procedure. The impact of commonly used doses of FFP to correct clotting lab results actually, or to reduce the risk of bleeding, is limited, particularly when the PT ratio on INR is between 1.5 to 1.9. Vitamin K use should be advised in such patients with a prolonged PT that is likely due to an acquired vitamin K deficiency. Like as I earlier mentioned, PT and APTT values do not reflect the true hemostatic status of the patient with advanced liver disease. These values need to be interpreted with caution in these patients. Liver Society recommendations endorse that prophylactic transfusions should not be given to patients with low bleeding risk procedures such as paracentesis. Whereas alternative procedures with a lower bleeding risk, for example, a transjugular liver biopsy other than a percutaneous liver biopsy should be considered for such patients. My today's talk would not be complete if I do not talk about the long-standing debate of fresh versus old blood that has always been with the clinician and the blood bank. There have been various trials, like I mentioned, RECESS, Transfuse, ERIP and INFORM, which have come to the results that there actually has been no difference in mortality. The MODS scores and there is no cutoff as such till now for fresh as well as whole blood. Now, fresh blood is advocated in some conditions, like I will say in intrauterine transfusions or in case of double volume exchange transfusions in neonates. But however, we have seen that blood more than 21 days, 21 to 28 days. And a standard issue is actually 35 to 42 days. So when we are issuing blood even 28 days, it is giving a good increment in patients, easily up to a packed cell volume of 3% we are achieving. Provided the quality of the stored blood and all the factors at the time of collection, at the time of issue are being followed according to the standard operating procedures. Coming to new transfusion triggers, an optimal transfusion trigger should actually avoid any delayed transfusion, avoid a premature transfusion, take into account the different degrees of anemia tolerance of different organs, has to be determined continuously and have a high sensitivity and specificity. So these are the transfusion triggers under evaluation. Mostly the clinical transfusion triggers that are being followed are hemoglobin and hematocrit depending on the tissue oxygen delivery, which actually should be the key figure for adequate tissue oxygenation at the tissue level. ECG, however, cannot be used for all. Then the oxygen delivery for tissue oxygenation, arterial lactate levels, organ specific anemia tolerance, then the near infrared spectroscopy, however, still not validated. Thank you.